Hello, everybody. My name is Dr. Muhammad Bilal Akbar. I am one of the surgical doctors from NHS Grampian, Scotland, actually. So today's topic of my presentation is basically a bit of surgery, anesthesia, and gastroenterology related. So the topic is actually which one to choose among pre-incisional or post-incisional Bupivacaine for pain relief in patients undergoing elective surgery. Literally means that when we go for different surgical operations, we use local anesthesia. Sometimes we use it before making an incision. Sometimes we use it after completing our surgery. But which one to choose, which one is better, that's the topic of my research. That's the topic which I am presenting today. All right, next slide, please. Okay, so first of all, what is pain? Okay, we hear this word a lot, pain, but what exactly is the definition? It's basically an unpleasant sensory and emotional experience arising from actual or potential tissue damage. The pain is highly personal. It's a very personal phenomena, subjective experience, which can only be accurately described by the individual who is experiencing pain. Like, different people have different threshold to pain, and different people perceive pain differently. So it's a very personal phenomena, which depends upon a lot of factors, which depends upon personal experiences, anxiety level, cultural backgrounds. There are many factors which take part actually in an overall perception of pain, if I can explain it. Okay, so next slide, please. So this is the pain pathway. So the pathway actually starts from the nociceptors, for example, on the skin, and then the first physiological process there is the process of transduction, as I have mentioned there in my slide. So but then the pain is transmitted from those nociceptors via sensory neurons, via somatic sensory pathway. It goes to the spinal cord, and a second order neuron starts from the spinal cord, decussate towards the opposite sides, goes into lateral or cerebellar, so spinothalamic tracts, and then those second order neurons decussate in the medulla, and then it goes to the higher brain centers via third order neurons. So this is the whole pain pathway. The processes involved in this pain pathway are transduction at the level of receptors, transmission through those neuronal circuit, neuronal synapses, perception of the pain at higher neurological levels, and then pain modulation and these are those process in which the perceived pain is modulated via our higher neuronal centers through some neuromodulators like endorphins, etc. Okay, next slide, please. So the important question here is why what is actually an ideal post-operation pain management? Okay, so what are the goals here? Obviously, our goal is for the patient to suffer less, so relieve suffering after surgery, then achieving early mobilization for the patients, reduce length of their hospital stays, and achieve overall patient satisfaction from their whole experience. We must take into account that medical, physiological, physical conditions of a patient, age of a patient, level of fear or anxiety, the surgical procedure itself, the type of procedure, if it's a and then the personal preference of a patient, which type of anesthesia they want to use, and response to the agents given. Multimodal pain therapy is recommended nowadays, which includes administration of local anesthesia, administration of non-steroidal and anti-inflammatory, and then different modules of giving analgesia. For example, giving patient control analgesia, giving epidurals, giving local analgesia alongside general anesthesia. The basic aim here is to minimize the need of opioids, as surgery may be the trigger for long-term opioid use in many patients, and which can be hazardous in long term, as the patient become addicted to opioids in long term. The need of better analgesic and timing of its administration is the key to surgery, to success. So this last point is very important here. There is a combination of different analgesia modalities and analgesic agents, which and especially the important thing here is to administer those analgesic agents at proper time to give the patient maximum benefit. Next slide, please. Next slide, please. Sorry, next slide, please. Yes, so why effective pain management is of utmost importance in post-op patients? Why we are focusing so much on post-operative pain? Because the pain is often overlooked, okay, and not adequately controlled. Up to 70% of patients experience severe post-operative pain. That's why we need to look into this. Post-operative pain causes increase in sympathetic activity, increase in heart rate and oxygen consumption, and delays early mobilization. So all these factors they increase hospital stay, and they hinder the patient from going home immediately or post surgery. Many studies have shown that effective analgesia reduces post-operative complications. The patient get up out of the bed early. The patient, their respiratory effort improves, okay, their oxygenation level improves, and they recover very good after the surgery if their pain is properly managed after the surgery. Next slide, please. So there is a concept of preemptive and preventive analgesia. So number one, what is preemptive analgesia? Preemptive analgesia administered prior to surgical incision or stimulus can modify peripheral and central nervous system processing of noxious stimuli, thus thereby reducing central sensitization, hyperalgesia, and allodynia. So basically, preemptive analgesia means that you create such an environment, you give the analgesia before giving the pain stimulus, and already your receptors are sensitized. So basically, your body does not perceive the noxious stimulus, and all those processes of transduction, transmission, perception, those are not initiated on the first place. This is a preemptive analgesia. What is preventive analgesia? So preventive analgesia can reduce nociceptors, pain reception, activation by blocking or decreasing receptor activation and inhibiting the production or activity of pain neurotransmitters by treatments given any time in the post-operative procedure. So basically what happens is you get the noxious stimulus, but after you get the noxious stimulus, you try to dampen it by blocking or decreasing receptor activations or inhibiting the production of neurotransmitters such as histamine, such as bradykinin, etc. Okay, so that is and those there are different methods, different modalities, and can be administered at different time during the surgery. Next slide, please. So what is the objective of my study? So the objective of my study is to compare the mean postoperative pain score with pre-incisional versus postoperative injection of local anesthesia Bupivacaine to prove that there is a difference in the mean postoperative pain score with pre-incisional versus postoperative injection of Bupivacaine in patients undergoing elective surgery. So I basically want to prove here that when I infiltrate my local anesthesia before my Bupivacaine before giving an incision, the results are better on visual analytical score than when I give the anesthesia after completing the surgery. Thank you. Next slide, please. So method. So I've chosen patients aged between 18 to 60 years undergoing elective surgery. I've divided them into two groups via computer-generated randomization. The cases in group A were given pre-incisional Bupivacaine, and group B were given post-operative Bupivacaine. And we assess them at 1 hour after the surgery, and we assess them regarding pain on visual analytical score. We know there are different scores for and we have used visual analytical score in our study. So what was the inclusion criteria? Patients of both genders were with ages in the range of 18 to 60 years, undergoing elective surgeries, patients who signed the written informed consent to be a part of our research project. What was the exclusion criteria? This is very important because we have excluded patients who were obviously allergic to Bupivacaine. We have excluded patients who were using steroids, who had any deranged coagulation profile, who were ASC, American Association of Anesthesia class more than 3. We have excluded patients who were diabetic or who were hypertensive or who had high BMI, because all those factors affect on our on our results. So that's why these are all our exclusion criteria. Next slide, please. Next slide, please. Yeah. So these are my these are the tables which are showing some variables, and the results are just below. So table number 1 shows study variable age in both groups. So we have divided them into 2 groups, each containing 632 individuals. So group A, if you can see that the main age is 47 years, and group B is 49 years. So there is not much of a difference between age, and standard deviation of 7.51. Minimum age is 18 in group 1, 19 in group A, group 2 B. And the maximum age is 16 group A and 16 group B. So there is not much difference of age between 2 groups. The mean age in group A was 47.56 plus minus 7, while in group B it was 49.13 plus minus 8. So there's not much difference in age in 2 groups. Next slide, please. Next slide, please. So duration of study here, you can see as well, there is not much difference between group A and group B. You can see the mean time is 53.47, 52.57 in group versus 52.67. Standard deviation of 21.13 versus 23.34. Minimum time was 30 minutes. That is same in both, and maximum time was 90 minutes in group A and 100 minutes in group B. So the mean duration of surgery was 53.47 in group A, 52.67 in group B. So there is not much of a difference in duration of surgery. Should not impact much in our results. Next slide, please. So gender distribution, and another main variable is gender. So males have different pain perception, females have a different pain perception. So we made sure that this variable also remains somewhat same in our study. So in group 1 we had 19 males, group B we had 18 males, group A we had 13 males, and group B we had 13 females, and group B we had 14 females. So in total 32 patients in group A, 32 patients in group B. There were 19 males, which basically is a ratio of 59.37 in group A versus 56.25 in group B. Next slide, please. So type of elective procedure in the study subjects. So there is a variety of surgical procedures which are included in our study. You can see we have laparoscopic cholecystectomies. We divided it 9 in group A, 7 in group B. Laparoscopic hernioplasties, 7 in group A, 8 in group B. Laparoscopic appendicectomies, these are elective or interval appendicectomies, 7 in group A, 9 in group B. Open cholecystectomies are 5 in group A, 6 in group B. Open hernioplasties, 2 in group A and 1 in group B. Open appendicectomies, 2 in group A, 1 in group B. Cesarean sections, we do not have those. So in total, we had 32 elective surgeries in group A and 32 elective surgeries in group B. So there are quite similar number of cases for each case. The reveals various type of procedures in both groups. This table. Next slide, please. So this slide has a lot of things, has a lot of data. So I'll go by just one by one because it is actually showing the pain the value of pain on an analytical score. So table 5, you can see post-operative pain with respect of both groups. Very important. So group A, you can see is 3.07 plus minus 0.67 as compared to group B, which is 3.59. So and p-value is 0.03. Okay. Next table 6, you can see gender wise, the pain perception gender wise. So in group A, 3.12 males, group B 3.477 males. So the p-value, the difference is 0.21. In females, it's 3.21 in group A, 3.53 in group B, and p-value is 0.23. Then age wise, in group A it's 3.1, in group B it's 3.44 for the patients who are younger, who are in an age group from 18 to 39, and in elderly patient or middle age patient from 40 to 60 years, pain perception in group A is 3.08, and in group B it's 3.47. So 0.200. You can clearly see in all of those tables in those groups, the pain perception is obviously better in patients who are getting preemptive analgesia. I'll come back to the results in the next slide, but type of procedure wise, in group 8, post-operative pain in both groups with respect to type of procedures. You can see here laparoscopic cholecystectomy, group A 3.1, group B 3.411, quite a significant difference here. Laparoscopic hernioplasty again 3.19 versus 3.45. Laparoscopic appendicectomy 3.0 versus 3.34, quite a significant difference here. Open cholecystectomy, this is really fantastic, that there's a big difference here 3.21 versus 3.86. So open hernioplasty again 3.17 versus 3.35. Open appendicectomy 3.09 versus 3.45. So p-value is 0.31. You can see the p-value is really great here. Next slide, please. Okay, so here are the results from last five tables. Table 5 is showing the mean postoperative pain in group A was 3.07 versus 3.59 in group B on visual analytical score. Table 6 is showing mean postoperative pain in males was 3.12 versus 3.47, and in females it was 3.21 versus 3.57. Mean postoperative pain was 3.11 versus 3.45 in group age group 18 to 39 years, and versus 3.47 in group in age group 40 to 60 years in group A and B, with p-values of 0.25 and 0.20 respectively. There was a significant difference as shown in table 8 in terms of postoperative pain in cases undergoing open cholecystectomy, where pain was 3.21 plus minus 0.78 versus 3.86. So a huge difference here, and whereas no difference was seen in rest of the variables. Okay, next slide, please. So conclusion. So keeping in view all those tables before, and I know there is a lot of data there in those tables, but overall you can see that the mean postoperative pain is significantly better in cases treated with pre-incisional bupivacaine as compared to the post-operative bupivacaine, and this difference was also significantly high in cases undergoing open cholecystectomy. So that is the conclusion of all this research, and all this data collection shows that the preemptive analgesia is giving good effects, or giving good results comparatively when as to the preventive analgesia. So for me, what are the benefits, or what are the plus points in this research? That the plus points are, obviously we have included we have touched the subject which is the subject of debate. Actually, different surgeons use different modalities. Half of the surgeons I've seen, they infiltrate the local anesthesia before starting their procedure. The other half, they do it after completing their surgery, after closing the wounds. So there is no hard and fast rule followed up of these up till now. So because this subject is a debatable subject, so I focused on effective pain management, and how to formalize, basically how to tell other people that which one is better, preemptive one giving before, or preventive one given after the surgery. This was my goal of this surgery, and I've included a variety of cases, and I've included duration, different time scale as well. What are the lows of this study? So the lows of this study, or potentially the things which can be a bias in this study, is that obviously we are giving general anesthesia in most of those patients, and different general anesthesias were used during the procedures. So that can be the low of my study, I would say.